Good morning everyone. I am Dr. E. Priya from Department of Public Health Dentistry. Today we are going to learn about Preventive Resin Restoration, commonly called PRR. This is an important conservative technique in dentistry that focuses on preventing caries progression while at the same time restoring small defects. It represents a modern shift in dental practice from aggressive cavity preparation to preservation of tooth structure. Over the next few minutes, we will go step by step through its definition, indications, types, clinical procedure, and its significance in preventive dentistry. What is PRR? Let us begin with the definition. A preventive resin restoration is minimally invasive restorative technique designed for managing early carious lesions, especially those that occur in pits and fissures of molars and premolars. Why pits and fissures? Because these are the most vulnerable sites of caries in young permanent teeth. Food particles, bacteria and plaque easily get trapped in these grooves and they are very difficult to clean with the toothbrush. PRR, that is preventive resin restoration, essentially combines two approaches. Preventive role of pit and fissure sealants and the restorative role of resin composite materials. So it is both preventive and restorative at the same time, which makes it unique. Now, when should we consider PRR? There are several indications. Firstly, it is recommended for non-cavitated or minimally cavitated lesions. These are lesions that are just beginning and have not progressed deeply. Secondly, it is indicated in patients with high caries risk. This includes children and adolescents who may have poor oral hygiene, high sugar intake, or limited access to regular dental care. Thirdly, it is especially useful in newly erupted permanent molars and premolars. These teeth are most susceptible to decay immediately after eruption because their enamel is not yet fully matured and occlusal grooves are deep. And finally, it is useful for occlusal surfaces where caries activity is limited to pits and fissures while the rest of the tooth structure remains sound. Next, types of PRR. Depending on the extent of decay, PRRs can be classified into three types. Type A involves cases where no caries is present but the pits and fissures are at high risk. In this situation, only a sealant is placed. Type B, when incipient caries are present, here, minimal preparation is done to remove the affected enamel or dentin and then a sealant is applied. Type C is used when there are small cavitated lesions. In this case, the dentist removes the decayed portion, places a small composite restoration and then seals the remaining fissures. So essentially the type depends on how far the lesion has progressed, but in all cases the aim is to remain conservative. Next we move on to materials used. What materials are used for PRR? The main material is flowable composite resin. This is used to fill any small cavities. Along with that, we use a light cured fissure sealant which provides a protective layer over the grooves. An etching gel, usually 35 to 37% orthophosphoric acid, is used to condition the enamel surface. A bonding agent is also applied to enhance the adhesion between the tooth structure and the resin. In addition, the dentist will use polishing and finishing tools to ensure the smooth final surface that resists plaque accumulation. Now, let's move on to the steps. Now, let's go step by step through the clinical procedures. Step 1, isolation. The tooth is isolated often using a rubber dam to keep it dry and free of saliva contamination. Step 2. The occlusal surface is cleaned. This can be done with the prophylaxis brush and pumice or by air abrasion to remove plaque and debris from the fissures. Step 3. If there are incipient caries, the dentist removes them using a small round burr or a spoon excavator. The goal here is the goal here is to uh, minimal caries removal. Only the infected tissue is taken out, nothing more. Step 4. The prepared fissure is etched with phosphoric acid for about 15 to 30 seconds, then rinsed thoroughly and dried. Step 5. A bonding agent is applied and light cured. Step 6. The composite or sealant material is placed carefully into the fissure and cured with the light. And finally, step 7. The restoration is checked for occlusion, finished and polished. The end result is a smooth sealed surface that prevents food lodgement and bacterial activity. This concludes the clinical steps. Then decayed fissures were opened using inverted cone burr or round burr. The retention of maximum healthy tissues and uh, amalgam restoration is also removed in the next tooth. In the next picture, the dentine was properly cleaned of the caries. Next, coming to the next step, the adhesive was forced down to the deeper parts of the fissure using applicator tip. Here we place the bonding agent using the applicator tips. And in the next step, the occlusal areas of fissures and cavities are filled with flowable composite. Then the cavity restores with restorative composite. Then in a post-operative view, there is a clear surface, polished surface without any carious lesion, and the high points are also checked. What are the advantages of PRR? Now, what are the benefits of this technique? Firstly, it preserves maximum tooth structure, which is the cornerstone of modern conservative dentistry. Secondly, it is minimally invasive, meaning the patient experiences less discomfort and the tooth retains its natural strength. Thirdly, it is cost effective compared to more extensive restorations. Fourthly, it is significantly reduces the need for future restorations because it prevents the progression of caries. And finally, PRR provides an excellent marginal seal which protects against micro leakage and secondary caries. Next, we move on to the limitations of this technique. Despite its many advantages, it has some limitations. It requires good patient cooperation, which may sometimes be difficult in very young or anxious children. It is also a technique sensitive procedure. If proper isolation is not maintained, the bond strength and longevity of the restoration may be compromised. And importantly, PRR is not suitable for deep or extensive caries. Once the lesion has progressed significantly into the dentine, a more conventional restoration or even endodontic therapy may be required. Finally, we move on to the conclusion. To summarize, preventive resin restoration is a valuable technique that bridges the gap between prevention and restoration. It is especially effective in newly erupted permanent teeth of children and adolescents. By sealing the vulnerable pits and fissures while treating a small lesion conservatively, PRR helps in maintaining the long-term health of the dentition. Therefore, PRR should be considered as a part of a routine pediatric and preventive dental care promoting oral health with minimum intervention.